Academy of Family Physician, Dr. Patterson.
Hi.
Hey.
How are y'all today? Who's having a good time?
Wonderful.
Somebody just told me they'd rather be doing a digital rectal exam. I'm Katie Patterson. Thank y'all for having us today. I appreciate the board's intent of this. We represent 1,000 family doctors, residents, and medical students, and I am in Indianola, Mississippi, doing full spectrum family medicine. We as family physicians recognize the urgency of what's going on in our state, and we want to be part of the solution. But we want you to be cautious before we adopt restrictive regulations and allow the physician concerns to be heard like you are today. We truly appreciate the work of the Governor's Task Force and find many of their conclusions very, very useful. However, we're concerned with the unintended consequences of the proposed regulations on our patients and the citizens of Mississippi. I want to tell you a story about Mary. I'm a family doc, so here you go. She's 68, she has congestive heart failure, she has diabetes, she has coronary artery disease, she has chronic kidney disease, and my goodness, she has really bad knees. She can't have surgery due to her current hormone comorbidities. She can't have non-steroidals because of her kidneys. She can't have steroids because of her diabetes. Uses 1 to 2 hydrocodone per day to enjoy life with her children and her grandchildren. She can go to the park with them or little league games when she medicates. She has to take 1 pill every morning to get out of bed and walk. Her husband of 40 years died last fall, and she has occasional sadness and anxiety that requires a small dose of benzodiazepine a few times a month, which would be in direct violation of proposed Rule 1.7i. Mary comes religiously to your clinic. She never misses an appointment, but does tell you that paying her copays sometimes is a little difficult on her fixed income, and sometimes getting to the clinic is difficult due to her not driving. Her PMP report is always spotless, 1 provider, 1 pharmacy. This is a patient I see every day in my practice, and my colleagues across the state in family medicine and internal medicine see very similar patients. An extra office visit or a drug screen that isn't covered by insurance could leave them choosing between another vital medication or a meal. The new regulations as proposed in Rule 1.7K would require Mary to undergo drug testing at each encounter. This drug requirement isn't specific and doesn't qualify the type of test, and could cost her anywhere from $20 to $1,500 depending on the practice. Also concerning is that scheduling drug tests will allow those who obtain drugs for diversion to know when screening will occur, which is convenient for them to take their medication on the day of the appointment. In Rule 1.7e, we are instructed not to prescribe any controlled substance to any patient who has consumed any other controlled substance or other drug not in the treating licensee's directions. The CDC recommends utilizing the drug screen to open a conversation between a physician and their patient and strengthen the physician-patient relationship. One of the unintended consequences of this proposed rule would result in termination of patients from a practice, resulting in patients seeking an alternative method of pain control, including street drugs. This is already happening without the current regulations in place and would worsen if they are enforced. Many of Mary's specialists have already said they will discontinue prescribing pain medication once the regulations go into effect, and some have already stopped prescribing after their proposal. Mary, like hundreds, maybe thousands of Mississippians in our state, will return to primary care to take care of them. That's what we do. Many of our members are concerned by Rule 1.14A6, changing the percent of pain management patients to 30% of a practice to be defined as pain management medical practice. In small towns and rural areas, this could easily become a reality for many physicians due to the lack of pain management clinics, the wait time to be seen in pain management clinics, and specialists no longer filling controlled substances due to these regulations. The requirement of the completion of 100 interactive live hours of CME in Rule 1.14J5 may also take physicians out of their practice, both urban and rural, and further decrease access to care for all patients. Mary is one of those highly functioning non-abusers who legitimately need low-dose opioids for their quality of life and to perform daily activities. All of the proposed regulations will leave the vast majority of these patients, like Mary, inadequately treated for their manageable and chronic pain. Many patients will suffer withdrawals, some will commit suicide. The PMP is a great source of information, and more family physicians are utilizing it in their daily routine. The proposed regulations in 1.3 and 1.7J read that a PMP report must be run on all new patients in a practice and every 3 months for patients being prescribed controlled substances. We definitely need clarification to ensure that we won't need to run a report on every new patient, only those being prescribed controlled substances. Limiting prescriptions to 7 days with an additional 7 days allowed as in Rule 1.7H also becomes a one-size-fits-all regulation. Many patients have a much lower pain tolerance and require longer periods of treatment. Complex surgeries, broken bones, and other ailments such as shingles must be adequately treated, and an explanation of how this is to be accomplished is not presented in the current regulations. While there's a lot of good in these proposed regulations, the Board of Medical Licensure does not regulate all providers, and these drastic regulations on physicians will drive patients to mid-level providers who could possibly provide a lower level of care and create further patient issues, including a worse state of addiction in Mississippi. I think we all can agree that there is room for improvement regarding physicians' prescribing practices. However, the practice of medicine should not be pushed into regulations that will injure or hurt our patients. Please allow the physicians in our state to practice medicine and utilize our knowledge and our skill to appropriately and safely prescribe based on individual patient needs and medical history. We are all advocates for getting the drugs off the streets and safe opioid guidelines for the protection of the citizens of Mississippi. However, let's not lose sight of the duty to care for the legitimate, non-addicted pain patients who have been caught in this crisis. We, the Mississippi Academy of Family Physicians, as the board, have a more thorough dialogue with physicians who are concerned about the unintended consequences that these proposed regulations will place on our ability to care for our patients. We want to be part of the solution, and I personally volunteer to help in any way that I can. Thank you for your time.
Here, here.
Thank you. Our next speaker is from Adult Acute Care, NP. This is Kim Ratcliffe.
I want to thank the board and especially Ms. Carrillo for letting me speak to the board today. I represent several nurse practitioners who work in long-term care exclusively. And I appreciate the board clarifying some things today for us that help us with people that are inpatient. That helped out tremendously. But I do want to bring to your attention a few things that we are guided by, so that maybe you will take a look at how long we can write pain medicine for, and the fact that we have to have opioids and benzos, diazepines, and we would like the permission to be able to write these prescriptions for 1 month at a time, which is what we do anyway in the nursing home facility. And I still think that the week or 2 weeks maximum is still applied to the nursing home. Am I correct?
No.
Okay, thank you. Then can you clarify that for me?
Yes, ma'am, we've said that several times, but we'll clarify it in the rules to make sure that people understand it only pertains to outpatient.
It's only for outpatient. Okay, let me just ask you a couple of real quick questions. The fax log, with faxing prescriptions to the pharmacy, will we need to keep a log of all those prescriptions in the chart or in the facility of each prescription that we write?
Do you not have that now?
No, sir. What we do now is, patients may come in the nursing home at 10 o'clock at night. They come in on the weekends. What I do is I fax a prescription from my telephone. I take a copy of the prescription and I fax it. And that fax copy to our Omnicare pharmacy that we use, they use that as the prescription for Schedule 2 through Schedule 5. If I'm in the building and I write a prescription, they take that prescription and they put it in with the drug EDK kit, the emergency dispense kit, that goes back to the pharmacy every night, and they take those prescriptions out of the kit. But as far as the ones that I take at home, I destroy those, or that I'm doing when I'm at Walmart or whatever, I keep them in my pocket and then I destroy them.
Well, I'm confused about something. You're an APRN, is that correct?
Yes, sir.
We don't give permission for APRNs.
I understand, sir, but trust me, whatever rules that you lay down for like the medical directors for the nursing homes, that whatever rules that you will state will wind up being the rules that the nurse practitioners will wind up having to follow. So that's, that's a question that I have, because other medical directors, when they're on call, if they're not sitting at their computer, they will have a transmitting device like that on their phone. If they're not at home, like if they're at Oxford for a football game, that's how they're gonna get a prescription to the pharmacy.
But you're talking about sending a prescription to the pharmacy fills and brings it to the nursing home.
Right.
And the nursing home dispenses it.
Right.
That doesn't pertain here.
None of that pertains to
It
this.
doesn't- If you have a third party dispensing the medication where there should be no diversion, and there's automatic pill counts, because you've got, the pharmacy board has rules on that, nurse board on, then that doesn't apply here. Now, if the nursing home patient goes home,
We don't send prescriptions home.
well, but I'm just saying hypothetically, they go home, it does apply. That's a prescription they would take themselves.
Well, now, the facility, under facility guidelines with CMS and Medicare and Medicaid, they dispense whatever narcotics they may have left, depending on what type of patient they are, Medicaid or Medicare, they will dispense. The facility dispenses home, not the provider. So I'm not involved in that, and I never write a prescription for pain medicine for a patient to go home. Okay. Thank you, sir. Appreciate the board's time.
Thank you. Next, we have from Singing River Health System, Dr. Rick Roden.
You weren't trying to skip me, were you?
Well, no, Rick, you didn't have any official capacity, so.
See, I disagree with that. I'm officially representing myself.
Very good.
Unofficially, I think I'm a concerned member of State Medical, Central Medical, Mississippi Psychiatric, and I would say represent a large number of very small practice physicians in the state. And a lot of things have been said, and I've sent detailed stuff to y'all already about specific things, because I don't think, listening to the whole group, we could sit here and try to pick each line and things that people don't want and disagree. I have to go along with what State Medical wants to do, which is to scrap it, and let's come back and be a ball-peen hammer and not a sledgehammer, and let's give us a chance to give some guidelines, and then see how that happens. Because I've already, without even going through what these changes are, I've already lost patients. I had to cancel a whole afternoon of patients to be here, so they're not being treated, I'm not getting income, and, so it's already started that. But these regulations will be a real problem administratively. So I speak in general about this whole thing, not just about specific things. So I'm going to read notes I've got here to try to shorten my talk. First, it's important to recognize the difference between a crisis and a chronic problem. A crisis is relatively sudden in occurrence, and serious with catastrophic consequences happen right now. The crisis demands quick action, often bypassing a more deliberate and inclusive response preferred for most problem solving. Examples of a crisis would be destructive hurricane, mass murder event, and we could probably put escalating opioid deaths. If it's termed a crisis, it is up there. That's the whole reason we're here. It's a crisis. It's opioid crisis. It's not benzos. It's not all the other control drugs. It is opioid. Chronic problem, which we have for a long time, may have serious consequences, but they have many complex aspects. You've heard about some of them here. They have to be considered at length, carefully and deliberately, in an ongoing manner, and involving everybody's input. Simple actions are ineffective and could do more harm than good. If that had worked, you wouldn't have this chronic problem to begin with. And I'm referring, as an example, to addiction and substance abuse and all the issues that go along with that can involve, lots of different medicines, but the crisis is opioid. My next point, regulatory changes should be about rapid actions, just about the opioid epidemic. It's the only crisis. That's all you read about in the paper. It's all anybody calls a crisis. It's the whole reason that just came up. It's the whole reason you had the governor's task force. Opioid crisis. Now, so that's one of my main points. I'm not saying I agree with everything about the opioids, because I know a lot, I don't treat pain, I don't use opioids, so, but I know a lot of people do, and they should have a strong voice into what kind of limitations are there. But I think this needs to be streamlined and limited to opioids only, which, you know, by putting all this other stuff, you see there's a lot of confusion here. You dilute the import of the purpose of the thing, which is to concentrate on opioid deaths, because now you're including all these other issues. And even though I support the MSMA recommendation, I support the part where they say scrap it, and let's really see what we're doing here, and let's don't do all these other little things that are extremely difficult administrative burdens for small practices. Third point is more specific to the negative consequences. There are many burdensome, confounding, and unproven elements in this proposal that need much more thought and input. Time prevents me from listing it. I think I had an 18 or 19 point thing that I sent to y'all that's more specific. But what happens is these are mandates. These become things that, you know, I keep hearing clarification and stuff, but we don't know what's going to be clarified, or, you know, if it's supposed to be 7 days, having to be 8 days, and you go get your license suspended. I mean, a mandate is something that is punishment. I think we ought to have guidelines. You know, we've already had, well, the AMA is against mandated PMPs. They've got, that's written in their policy. This proposal calls for extensive and separate record keeping, specific frequently requirements, intrusive audits, yearly summaries. I don't have room to keep all the extra charts and stuff. There's little evidence that these would impact the broader chronic problem of substance abuse, as its proponents expect, without causing unintended harms to physician practices and patient care, not the least of which are threats against good physicians' licenses and fewer patients being treated. And this is my last, and this is what we know. Physicians, politicians, media, and citizens are in general consensus that there need to be some immediate actions taken about the opioid crisis. It's opioid crisis, not the benzo crisis, not the Adderall crisis, not your lower level medication crisis. This is coming by opioid, mostly illegal. If a regulation is to be urgently formulated, it should be limited to that. This meeting, the physician outcry, should be enough evidence that there's not much agreement, much less any kind of consensus about all the rest of these regulatory changes. And if you don't have that, and then you try to institute it, there's going to be a great number of negative consequences that you've already heard about. I think that we ought to be respecting and augmenting physicians' experience, training, and judgment, as opposed to more rigid cookie-cutter mandates. Use guidelines, not mandates. We've always complained about mandates from government. We have mandates. Well, here's a mandate from our state government. To address any other non-opioid drug issues, I think there needs to be a separate, delayed action, allowing much more time for research, transparent deliberation, formal input, and practicing physician specialists in Mississippi, including the small specialties. I got one computer, got one full-time secretary. She doesn't have any time to be checking PMP. I'm going to have to check the PMP routinely. I keep all kinds of copies of my prescriptions. I see family members. I get backup people. I spend a lot more time with patients than an average family doctor does. And I think that it's much more appropriate and it's much more effective at watching out for abuse. And I haven't had any trouble with it for 40 years. Then just routinely have to check something that's going to take time away from my patients, and it's going to be just a really terrible administrative burden. Now, the one thing I would say definitely about the wording, we need to remove everything that talks about psychiatric patients, psychiatry. You know, there's not any other mention of certain kind of patients in there. You know, if you're going to have a rule, it's just to treat patients in general. Don't be putting psychiatry in there, and another kind of discriminatory way to note who you think needs to be involved in this whole thing. So I'm against the whole thing. I'm not against doing something about the opioid crisis. I think something needs to be done there. I think some details need to be looked at, but I think we need to wait and not include all these other drugs that are not part of the crisis. They can be a problem, but they need a lot more time and a lot more input to come up with the details to solve it. Thank you. I do have one slight other complaint. I really think this was a good situation. You know, that be standing for 2.5 hours and be dehydrated, waiting for all this to happen. So this should have been a little more planning, I think, for people here. Thank you.
Thank you. Our next speaker is from Singing River Health System. Randy Roth is not here. Okay. Mississippi Sports Medicine, Dr. Walter Shuffle.
Well, first of all, thank you guys for what all you do for the practice of medicine in Mississippi. I know sometimes it's a thankless job. And I'm here, I came for one big reason, but according to Randy, prescriptions of opioids for acute pain, that you could write them a prescription for a week with one refill. Because if we have to look at the PNP every time in my office I write an acute opioid, which is the vast majority of what I do, we'll be looking at it all day long. So I don't have any problem of looking at it after a prescription and one refill. In fact, I think you probably should, because I do it all the time. I get good information from it. But that was my main concern, but I also had some constructive things, maybe common sense things to add on. And I recognize whatever's done about this is going to have unintended consequences. You're not going to make everybody happy, and you're going to be treading on somebody else's toes when you do it. But if you don't, nothing's going to improve, I can tell you that. But I've been in practice here for 37 years, and I would commend you on limiting prescriptions to a 7-day supply. That's obvious, practical, good sense, because people use about 40 or 50% of their prescriptions, and somebody steals them out of their medicine cabinet a month later when they come over for dinner. So that makes sense, okay? Benzodiazepines, I've heard some testimony here. I think maybe you guys need to look at that. If it's chronic use of it, maybe that falls into another category. One thing I've heard a recurring theme all day today is that what's a good indication for me may not be a good indication for another doctor in Indianola or another doctor in Singing River. We desperately need a commission by the governor, the state board, or somebody to sit down with multi-specialty, appropriate experts and write some guidelines for the use of opioids, what they're good for and what they're bad for, okay? A lot of our prescribers were trained within the last 15 years, which was the pain decade, where we were encouraged to give buckets of pain medicine. I thought it was the craziest thing I ever heard when they were saying that. But unless you train these people in the right way to do it, they're going to keep doing it. They may go to the PNP, put it in their chart, and keep writing the prescriptions. Then they're okay, right? So we need to re-educate our prescribers. As you can see by the charts, I don't know if you have a copy of my letter that I wrote, but there's a chart from the FDA that shows as surgeons and emergency room physicians became aware of the epidemic 3 or 4 years ago, our use and our prescribing of opioids has fallen off the table. But that shows you who's writing them. Now, I'm not saying these are inappropriate, But we need guidelines, we need rules. Nobody taught us this in medical school, okay? So what's appropriate for one may not be appropriate for another. But there are appropriate guidelines, and there are misuses that can be well delineated. I think that the state medical society has a good idea when they say you need so many continuing education credits each year, but the way they're doing it is haphazard and pretty worthless. They need to sponsor courses where you learn the appropriate guidelines once they're made for opioids and how to do it and how not to do it. You should develop guidelines for chronic pain, okay? And I thought about this, you know, if you have somebody with chronic pain, maybe an opioid is the only solution. But if you send somebody to Whitfield, you have to have 2 doctors to sign off on that. If you assign somebody to lifelong addiction to opioids because they have arthritis in their knees, nobody has to sign off on it. Maybe if you had to have 2 physicians sign off on a chronic opioid use, at least you'd have somebody looking over your shoulder, and it wouldn't be done serendipitously. The one big thing that I would recommend, and I do this with a little hesitation because you hate to put a sledgehammer over your head, but I would propose that the PMP be utilized to help stop the overprescribing of opioids. The only way to do that is to have an appropriate board, and maybe it needs the governor's and the legislature's intervention to write the appropriate laws if it's against the law now, to have somebody else monitor this. It's a good tool now, but as you can see, if you look at the stuff, this is a patient that I see all the time, 52-year-old, 42-year-old, 300-pound lady with arthritis in her knees and fibromyalgia. And she has had a benzodiazepine and Percocet every month for 87 straight prescriptions from the same provider. There it is right there. That's the key to the vault. If you want to save lives and decrease bad use of opioids, then maybe there's a commission or a board that oversees the PMP. And these things come up like red flags. I mean, it's just, bam, there it is. Go and talk to that physician or prescriber and see if they're meeting correct guidelines for the administration of it. Maybe they are, but I'll guarantee you in this patient they're not. You know, you don't prescribe opioids for a 42-year-old with arthritis in her knees because she weighs 300 pounds. You don't make her an opioid addict. So that's the key to the vault. You've got it. You've got to learn how to use it. And it could be misused, yes. But unless you do something like that, this isn't going to stop. They're just going to go to the PMP, say, well, dictate in there, I saw the PMP, write a prescription anyway, and keep right on the road. Because you guys don't have the manpower to go check behind and see if people are doing it. This is really a suggestion. I could probably write all the prescriptions the rest of my career and never be checked. The odds would be you'd never come looking. Because the manpower it would take to check on that one regulation is enormous. But the computer will do it for you, and the PMP will do it for you. One last thing, and I'll skip around a little bit. If you're successful in what you do, there is going to be a significant spike in street drugs, heroin use, deaths, and overdoses hitting the emergency room. So part of the education of re-educating these providers is where do you send people? What do you do with these people when they walk in? What I do with this 42-year-old walks in my office that's an opioid addict? I don't know. I'm an orthopedic surgeon. I don't know these things. Give us the tools to try to help these people. Otherwise, you're just going to have a bunch of dead people from heroin overdose. Again, thank you for paying attention to these few concerns. I hope I have been constructive rather than critical, because I know you guys have a tough job, but somebody has got to do something. We all recognize that. Thanks.
We don't have the legal authority just to pull up PMP.
then the legislature or the governor or somebody's got to get it.
It says you do.
That's,
On
Because
in
if-
your instruction, it says that y'all do.
That's the key to the vault. That's who's getting the prescriptions. I mean, this lady has had 120 controlled substances a month for 3 years.
Executive for point of sale. That's what you're saying.
Well, you know, and maybe it's appropriate.
We have the legal authority to pull up PMPs on on physicians that we're investigating. We can't just randomly say, Walter Shelter, we're gonna run PMP.
You don't have to random, you could put some guidelines in that thing and say, when somebody's writing 5,000 you know,
We've talked to Ms. Christopher about
Percocets.
that, and that's a move in the right direction. You
Yeah.
have a tickle point.
and it's gonna have to be,
Can't get out.
you know, the governor's office and the legislature's gonna have to get involved, and maybe even the Supreme Court rule on it that it's constitutional. But there's the key to the bank, right there.
it's hard to say what is overprescribing. That obviously is. But where does that trip over, you know?
And that's where you write in the guidelines. You know, you gotta have some guidelines and some rules, and they're gonna step on other people's feet. I realize that. But if you come visit me and you say, we got this PMP, we got a little problem with it, let's go look at the charts. If I can't convince you that it's appropriate use, then I need to have my tail clipped, or people are gonna die.
Thank you, sir. Good point. Due South Neuro Spine, Dr. Jeff Summers.
Thank you. I don't represent New South on this. I'm going to talk more about the regulatory stuff. And
Speak up, Jeff.
I'm the pain management representative for Jurisdiction J with CMS as well. Now, that's what I'm going to talk on. I'll start on 1.7, page 12, 1.7K. Just the point of service drug testing, each time a Schedule II medication is written.
Excuse me,
Yes.
We
you
can't
have
hear
to
you.
speak up or slow down.
Okay. Point of service drug testing, each time a Schedule II medication is written. And I obviously understand the intent of that. Most societies involved in chronic pain recommend random testing because drug diversion is not typically going to be picked up when you can anticipate every single drug screen. But a more significant issue is that insurance companies won't pay for that, has been discussed. And CMS won't as well, but it's also, this is not unique. Other states have tried it. Florida's tried it, Indiana tried it. They were sued by the ACLU and backed down both instances because they felt it was a violation of the Fourth Amendment to get protection against unreasonable search unless there was reasonable suspicion of abusive behavior and violations. They felt that forcing a patient even to sign a consent agreement that says you will submit compulsory testing was also a violation of that. And again, both times the states backed down. They actually went as far as to say that the federal government said through the assistant attorney's office that ordering drug tests is a shield against investigation by medical boards of licensure or law enforcement agencies not due to suspicion of drug abuse is considered not medically necessary and even potentially fraud. And Indiana was only trying to make one mandatory drug test per year, not one on every visit. And it would be difficult. I mean, you can do whatever you want, but you're probably going to have to anticipate that this will probably be something decided in the courts at some point. Indiana just recommended just change it to what is felt to be by the provider medically necessary. And this is just an FYI. I understand the intent of testing, but I don't think that from a regulatory standpoint, it'll go unchallenged. There's another question. I had another issue, and that's on page 4 under legend drugs. And Dr. Eastman, for a second, made a mention of something, and I just want to clarify that because that might be very useful. The question is, the pertinent part is, whenever you administer a legend drug or controlled substance, you must have a complete record and do an examination, and it's a good faith examination. And you understand that controlled substances, the issue is, and it's not discussed because it says that you must have these exams, is if the treating physician is not available on call, that's maybe what you were alluding to, if they're not available on call, and for example, it's one surgeon's covering another surgeon's practice while he's, it's the weekend, for example, and they call in and they were put on an antibiotic and now they've developed a rash to that antibiotic, or somebody's treating a patient with a flu and a family member now is getting symptoms, and you've got to get these antiviral agents in within 48 hours to do any good at all, or it's muscle pain after injection and somebody else is taking the call for you. The question becomes, can that person then see that patient without a physical exam? Is it okay to switch antibiotics on the phone because it's not addressed? And if it's not okay to do that, your options are have the patient come from Pontotoc to Jackson in the middle of the night to get a prescription for antibiotic, or just to say, yeah, your family member has the flu and everyone would recommend you take that anyway. Or wait till Monday when it's too late perhaps for antibiotics or antivirals, you've already bought a different problem, or you send them to the emergency room. Or try to rough them off on another provider that might have weekend access more locally. And if the intent is just to cover the practice, which I thought you might have alluded to, then that makes sense. I want to say that the governor's task force did not include the term alleged drug and only referred to controlled substances in their document. That seems to be something that's been added. Finally, talking about the rules of what's a pain management clinic, and this is kind of going back to what Dr. Shelton was saying too, because I completely agree with one of the things he said. We have rules which define what a pain management practice is. I understand the intent again. Part of the big problem is that people take it on themselves to become de facto pain clinics anyway, because all their patients are getting pain medicine. And it says if you hold yourself out to be a pain management practice, but it doesn't. Does that mean in your billing or your advertising you're saying yes, we're a pain management practice, or is it just you're providing pain management services? Because if you're fixing broken joints or anything like that as part of your practice, or sports medicine injuries or something like that, those are pain management services. So I don't think the intent of the board was to call those de facto pain clinic, but that might be something to be clarified. But if you meet the 30% threshold, then let's assume that's what it is. You get registered and you get a certificate that allows you to do all this. It defines the rules and registrations, and it goes on. You can say what the educational requirements are due. At the end of this process, you are now a registered and certified pain management practice in the state of Mississippi. So I'll move on now to go to page 11, which has come up several times. It talks about certain thresholds of medications, and once you get over 100 milligrams of morphine equivalent, you have to refer the patient to a pain management specialist. But have we allowed a means by which somebody with perhaps at most 100 hours of CME credit that might have been in some resort somewhere, and because they felt like it's a burdensome requirement, are they the pain specialist you're talking about? Because there is no such thing as a specialty of pain medicine. You can get inadequate qualifications recognized by the American Board of Medical Specialists. You can get added qualifications in certain core specialties such as physiatry, anesthesiology, neurology, but you can't, there is no recognized specialty of pain medicine. And my concern would be that if somebody might find it a pretty good marketing tool, let's say you're a pill mill, and we'll use that term. If you've already registered 50% because all of your patients are getting, now you're defined by the board as a pain specialist, and you can actually take referrals from other people, other practices that might be more legitimate if that meets the board's definition of what a pain specialist is, because under definitions, pain specialist is not defined, just pain management practice. And one of the biggest problems I see in what I would label pill mills is not that they're not providing pain medication. That's all they're providing. And if your only treatment is pain medication, you can't expect that patient to ever get better legitimately. And I don't care what the condition is, because if the only thing involved is time, there's nothing about an opioid that's going to change the trajectory of the underlying problem. It's just not going to happen. Consultation, to me, is more important than actually sending to a pain specialist, because some of them, the only tool in their bag is a prescription pad. And a lot of times for chronic pain, there's simply no medication that's going to manage that and end that condition. And if somebody's got knee pain so bad that for 84 months they need to have benzos narcotics, I'd like to know that somewhere down the line, they saw a pain specialist, an orthopedic specialist, and perhaps even, if that guy doesn't feel he's qualified, someone beyond that. But outside consultation is probably more important, or as important, as just getting to a pain specialist who, I really can't tell by the way the wording is, but you might just be able to go to 100 hours of CME, which sounds like a lot, but it's not even a month of residency training, and now you're a certified registered pain specialist. It can take, you're already registered because you had your pill mill, and now you're open for business because all these other people aren't going to be able to get into them. Other pain clinics that might offer treatment other than just prescriptions.
The intent of that is that be a pain practice, such as yourself. That's the intent, but we probably can clarify.
And the next speaker